Thank you, Vipin, for the kind introduction and means laying the groundwork. So these are the three pillars right now of the standards of care regarding the treatment of diabetic nephropathy, and to slow down CKD as well as the CAD progression in patients with type 2 DM. Now there is another pillar which is being slowly built. So that is the GLP-1 RA and the GIP-1, which is not being depicted now, but slowly that is also going to come into the picture. So right now we need to add a patient on RAS inhibition plus a non-steroidal MRA and SGLT2 inhibitor. So these three are the standards of care right now. And all three have got very strong evidence and are relatively safe and are level A guideline recommendations now. So, like Dr. Vibin told you, urine ACR is an important surrogate marker of kidney disease progression and is a predictor of adverse cardiovascular events. So, this is a study which shows that treatment effect on 6-month change in albuminuria, there is a 27% risk reduction in the composite kidney outcomes. And a 30% fall in geometric mean urine ACR over 6 months has been associated with a 27% reduction in risk of composite kidney outcomes. And we all know that albuminuria is also associated with a high cardiovascular death in patients with type 2 DM, hypertension, CKD, and heart failure. And like Dr. Vibin elaborated the various causes of microalbuminuria, heart disease is one of the causes of microalbuminuria along with diabetes mellitus. So these are the various guidelines which recommend the addition of Findrinone in patients previously receiving SGLT2 inhibitors. So including KDIGO, ADA standards of care and ESC 2023. And this is a Fidelity SGLT2I subgroup analysis. So there is consistent cardiovascular and kidney benefits and improved urine ACR irrespective of baseline SGLT2 use. So this is the urinary ACR reduction with Findrinone versus placebo at month 4. So this is without baseline SGLT2 reduction, and this is with baseline SGLT2. So there is significant reduction along with SGLT2, but there is a good reduction otherwise also. So the risk of progression to kidney failure, heart failure, and death can be dramatically reduced with the simultaneous use of new therapeutics. So this is the anticipated survival, event-free survival with optimal therapeutics in people with diabetes and CKD. So if you look at the hypertensive heart failure, so there is a increase in lifespan of 3.1 years. If you look at all-cause death, there is a increase in survival by 2 years. So when you look at kidney failure, so it goes up by 4.9 years, and when you look at the composite kidney outcome, so that goes up by 6.7 years. So this is next will be the confidence study. So this is the simultaneous use of Findrinone and SGLT2 inhibitor. So confidence was a study which investigated the efficacy and safety of simultaneous initiation of Findrinone and SGLT2 inhibitor in CKD and type 2 DM. So it was a randomized, double-blind, double-dummy, multi-centered, 3-armed parallel group phase 3 study. So the 3 arms were Findrinone and empagliflozin. The second arm was Findrinone, 10 or 20 milligrams OD and placebo. The third one was empagliflozin and placebo. And they were followed up for 180 days, and then there was a follow-up period of 210 days. So the primary efficacy was a relative change in urinary ACR from baseline to day 180 for combination versus empagliflozin and a combination versus Findrinone. The secondary safety endpoints were the EGFR changes and adverse events. And the eligibility criteria was type 2 DM with a HbA1c of less than 11, EGFR of 30 to 90 ml per minute, and a urinary ACR of more than 100 to less than 5,000 milligrams per gram. And the exclusion criteria was a serum potassium of more than 4.8 millimoles per liter. So another advantage was it consisted of a huge diverse range of patients with CKD and type 2 DM. Now, one of the criticisms of Fidelio and Figueroa was that the Asian population was very less because it was more of a Western-oriented study. So, so there were 800 patients, and there was the Indians included were 133. That is about 16.6% of the population, and 75% were males and 25% were females. The mean age was 66.5. The BMI was 29 kilograms. And Asians constituted the most often, so that is 46%, followed by whites, then African blacks, and then others. The mean EGFR was 54 to start with. Mean urinary ACR was 579. The serum potassium was 4.5 baseline and HbA1c was 7.3. And 88% had hypertension, 28% had ASCVD, and 16% had diabetic retinopathy. And almost all of them were on AC inhibitors and ARBs, and and about 23% were on GLP-1 RAs. So this is the means study outcomes. So when you look at the baseline and when you compare with day 14, so you can see that there is a significant reduction in the proteinuria. So the green is empagliflozin, then the orange one is Findrinone, and the blue is combination. So the combination scores over both the empagliflozin and the Findrinone group. So when you look at the day 30, so there is a reduction, and by day 90 there is a 49% reduction in the combined group. So when you look at 180 days, so there is a 52% reduction. So there is a 32% greater reduction versus empagliflozin and a 29% reduction versus Findrinone. So then they stopped the drug, and then they followed the patient up for another 30 days. So this is what they found. So once you stop the molecule, so irrespective of the drugs, your urine albumin goes up. And 70% of patients simultaneously initiated on Findrinone and an SGLT2 achieved the ADA recommended target of more than 30% reduction in urine ACR. So confidence complements the real-world evidence in supporting the combined use of Findrinone in the SGLT2. So again, combination scores over both SGLT2 and Findrinone alone when you combine the percentage reduction. And Fountain is another retrospective observational study. So by month 4 and month 12, combination scored over Findrinone or SGLT2 with SGLT2 at baseline. So there was a reversible reduction in BP in addition also. So that is another added advantage. But if you look at that, there is an initial GFR decline. So one of the problems with our patients is a lot of them are creatinine centric. So what happens when we add on these drugs is there is a reduction in the intraglomerular pressure, and ultimately the creatinine tends to go up initially. So when you add both of this together, there is going to be a sudden spike in creatinine, which might not go well with a lot of patients. So another option will be you can start SGLT2 initially, you allow the step kidney to stabilize for 2 weeks, and then you add on the Findrinone. So that might be another practical feasible option for our patients. But then, though there is an initial fall in GFR, then it slowly picks up and then it stabilizes in the long run. And practically what we see is in the longer run, their creatinine starts coming down, and a lot of them do stabilize. Even though their sugars are uncontrolled, a lot of these patients' creatinine gets stabilized. So another fear is hyperkalemia. Means the main fear of Findrinone is hyperkalemia. ഈ കടിക്കുന്ന പട്ടിയെ വില കൊടുത്ത് വാങ്ങണോ എന്നുള്ളതാണ് what a lot of them think, because it is an expensive drug, and hyperkalemia is on most of the patient's mind as well as in the physician's mind. But the incidence of hyperkalemia is much less in Findrinone when you compare with the other melanocorticoid receptor antagonist. So this is the emergent hyperkalemia. When you look at the combination, Findrinone alone, it is 11.4%. In combination, it is slightly lesser because you're adding an SGLT2 inhibition. But the hyperkalemia events leading to discontinuation of drug is much less. So the overall treatment adverse event profile is almost similar. So serum potassium level elevations of more than 6 were uncommon in patients simultaneously initiated on Findrinone and SGLT2 combination study. And the AKI incidence was 1.9% in combination, because this is to be expected. This is surprising because AKI incidence in empagliflozin in this study is 0. But practically what we see is a lot of patients do develop AKI in our population. Findrinone, we hardly see any AKIs in our population, but SGLT2s, that is not the case. So symptomatic hypotension incidence, combination, it was 1.1%, but Findrinone and empagliflozin, there were none. So the confidence study summary is that when you add on Findrinone and SGLT2 together in patients with the CKD and type 2 DM, there is an early reduction in urinary ACR, which is significantly greater than with either agent alone. and there is an additive reduction in urinary ACR up to 52%. And 70% of patients receiving the ADA achieved the ADA recommended target of more than 30% urinary ACR reduction. And the overall adverse event profile was similar to either agent alone. So these are the key conclusions. CKD associated with type 2 DM remains a global issue, and patients have a high risk of CKD progression despite advances in treatment options. Confidence provides support for a simultaneous approach to initiating Findenon and an SGLT2 inhibitor, complementing existing real-world evidence for Findenon and SGLT2 inhibitor combination therapy. And the findings from confidence will improve the confidence of physicians and will help initiating more patients on these good drugs. And Findenon is an essential treatment pillar in CKD with type 2 DM and is a standard of care now. Its early combination with an SGLT2 inhibitor should be considered and as an optimal approach to rapidly reduce albuminuria and the associated risk of adverse cardiovascular and kidney outcomes. So these are the various guideline means recommendations now. If you look at all the guidelines, it is level A recommendation now. And Findenon is approved in India with the same indication as the US FDA. And Findenon is indicated in adult patients with CKD associated with type 2 DM to reduce the risk of sustained EGFR decline, end-stage kidney disease, cardiovascular death, non-fatal MI, and hospitalization for heart failure. So this is from the Fidelio DKD and Figaro DKD means algorithm regarding management of hyperkalemia. So you should start Findenon only when the EGFR is more than 25 ml. And you can continue Findenon when the GFR drops, but use it with caution in patients whose GFR is less than 50. And treatment can be continued even if they go into dialysis or when they reach end-stage kidney disease, provided their potassium is normal. And you should only start Findenon when the serum potassium is less than 5. You start with 10 milligram once a day. And monitor potassium after 4 weeks and then after 4 months and then every 4-month intervals thereafter. After 1 month, if the potassium is less than 4.8, you can increase it to 20 milligrams once a day and then monitor serum potassium again. So if the potassium is between 4.8 to 5.5, then you can continue with whatever dose they are on. If the potassium is more than 5.5, you discontinue Findenon. You look at why the potassium is going up. If they are having a high potassium diet, you reduce the potassium. If they are on taking NSAIDs or anything by the side or some other Ayush medications or anything, stop them. Follow a strict diet and then reassess and then restart Findenon once the potassium is less than 5 with a smaller dose.